Good afternoon. I'd like to call the Health Commission Community and Public Health Committee meeting to order today on August 15th, 2023.
Thank you, and I'll call the roll. And commissioners, please make sure you have the mic as close to your face as possible. I will call the roll. Commissioner Gerardo.
Present.
And Commissioner Chung.
Present.
I will read the land acknowledgement. The San Francisco Health Commission acknowledges that we are on the unceded ancestral homeland of the Ramaytush Ohlone, who are the original inhabitants of the San Francisco Peninsula. As the indigenous stewards of this land, and in accordance with their traditions, the Ramaytush Ohlone have never ceded, lost, nor forgotten their responsibilities as the caretakers of this place, as well as for all peoples who reside in their traditional territory. As guests, we recognize that we benefit from living and working on their traditional homeland. We wish to pay our respects by acknowledging the ancestors, elders, and relatives of the Ramaytush Ohlone community and by affirming their sovereign rights as First Peoples. The second item on the agenda is the approval of the July 18, 2023 committee minutes.
I move to adopt the minutes.
Second.
There's no one on public comment. So you two can please move forward with the vote.
Aye.
Aye.
Great. Item 3 is the BHS internship pipeline.
Do you think, should I adjust this mic?
Yes, please.
Okay.
You're taller than the average person who stands there. And just let me know when you want to go to the next slide.
Okay. Thank you. Okay, this feels good. All right, good afternoon, commissioners, staff, and members of the public, if there are any here today. For those I don't know, my name is Ryan Fuimaono. I'm the internship coordinator with Behavioral Health Services, and I'm happy to be here this afternoon to provide an update to our internship pipeline programs within BHS. Next slide, please. Here's a look at what we're going to cover today. After a quick glance at an org chart just to see where my role sits within Behavioral Health Services, we're going to take a multi-year glance at our program numbers over the past 2 years and looking into this coming academic year. Then we're going to zoom in and take a closer look both at last year's cohort of interns as well as this coming year. Then I'm going to share some highlights about the Multicultural Student Stipend Program we call the MSSP, and then I'll briefly share some challenges and opportunities. Next slide, please. So as you see here, my role down there at the bottom sits within the Office of Justice, Equity, Diversity, and Inclusion, AKA the JEDI team. We love our acronyms in BHS. I sit alongside programs like our peer support services programs, our equity interventions team, our MHSA or Mental Health Services Act programs, as well as, who didn't make it onto the slide, and that's my mistake, is our trauma-informed systems team. Their work is really important and they should also be here. Yeah, and before we move on to the next slide, I'll just say that I'm not alone in this work of helping to support the cultivation of the next generation of behavioral health workforce. There are folks in other divisions that are doing similar work to mine that are welcoming in interns who are studying their graduate degrees. These are folks like Rita Perez in primary care behavioral health, Justin Dotterman out of ZSFGH Hospital. And so we are all together in this work. And shortly after I was hired in 2021 in this role, DPH HR hired a workforce initiatives coordinator. Her name is Maribel Mora, who's been working to convene regular meetings of all of the internship coordinators across the department to support interdepartmental coordination and communication, and also to look at streamlining onboarding processes. So I just want to mention those folks as well. Next slide, please. Here is that multi-year look at the numbers. So starting up at the top on the left-hand column, we'll see that year that I joined as internship coordinator, we were right in the heart of the pandemic, shelter in place. And despite that, we were able to host 4 civil service interns / trainees at 4 BHS sites. We added a whole slew of academic programs and schools to our lists of academic partnerships that year. And we ran our stipend program, the MSSP, and were able to award 24 students with stipends to support their training. 4 of them were those civil service interns that we hosted, and 20 of them were placed at CBOs, community partners. Moving into last year, 22-23, we see a huge jump in the numbers. We went from 4 civil service interns to 23, placed at 12 BHS sites. And on the next slide, we'll see where those placement sites were. We continued to add schools and programs to our academic partnerships, including 1 undergraduate placement out Chinatown North Beach, which came as a response to the Chinatown staff saying we need to develop future health workers that are bilingual in Asian languages. And so we partnered with the City College Community Health Certificate Program to add that as a placement site. And then down the chart, you'll see that we expanded the MSSP budget by $150,000 last year. Thanks, and we'll talk later on more about that, but I just want to shout out to Dr. Cunnins, our director, and the support of the BHS executive leadership team that really saw this as a way to support and foster that future workforce. So with our bigger budget, we were able to award 60 awardees, more than double what we had done the previous year. And you'll see that 9 of those came from that cohort of 23 students that we had placed that year within our civil service programs, 5 within the larger department, and 46 interns training at community partner agencies. Now moving forward into this year that we're just now in fact, in the next hour, we're gonna have our first 3 interns show up downstairs for their DPH badge. So it's happening as I'm speaking. We're expecting 18 students to onboard across 10 sites, so a slight dip in the numbers. And the note I have here around growing demand for online schools, I just wanted to mention this because in my 2 years of being in this role, I've received a lot of inquiries from students that are living and working in the Bay Area, but who are pursuing degrees at online schools. And these are schools like Columbia's online MSW program, Tulane has one, Antioch University. We're seeing a lot more schools offer curriculum online. And including some of the current employees who are concurrently going back to school to get their degrees. 2 of them from last year were students of online universities. And I know, Commissioner, you had a question of whether these schools were accredited, and the answer is yes. In order to be placed at a BHS site, we have to have an affiliation agreement between the school and the Department of Public Health. And those happen through partnering with the city attorney's office. And so every student that we place has a current ACA affiliation agreement. Sometimes they call them MOUs. And those specify accreditation, they specify that the schools have the proper insurances and various liability things. Yeah. But I am seeing it more, and I think, it's kind of, I do see it as an equity issue too, as folks are trying to figure out ways to advance in their careers as they live and work in the places that there are, and not everybody's getting into the Bay Area schools. Yeah. San Jose State is another one that offers an online MSW program, and that one has been around since 2016. So we're seeing new ones, and then there's also some that have been around for some years now. All right, next slide, please. So zooming into last year's students, you'll see that we placed 23 student interns across 12 civil service sites. And there you have the programs listed for you. On the next slide, we'll see kind of where those programs live in terms of systems of care. But just to talk through it briefly here, number one, Bridge and Engagement Services Team. I hear them also being called the BEST team. That's a new program under the Office of Coordinated Care. And that intern was a health worker who was concurrently going back to school to get his MSW to hopefully move into a 2930 clinician role in the future. What else did I want to mention about this list? I'll just highlight the ones that hosted employees. So was that number one? Also, number 11, Southeast Child and Family Therapy Center. They also hosted their employee who is a health worker who was going back to get her MSW, and she did what we call an employment-based field placement. And also, South of Market Mental Health hosted an employee going back to school. Yeah. Next slide, please. So here we have that same information, but just laid out in this org chart view so that you can see under which system of care these placement sites are, and how many of what discipline students they hosted. Yeah, this view kind of helps me organize that information in a different way. Next slide, please. This slide shows the degree breakdown for those interns last year. And yeah, I won't talk us through it, but you can see how many students were pursuing what degree and from what school, including those 2 community mental health certificate undergraduate students from City College there at the bottom who were at Chinatown North Beach. Next slide, please. Yeah, this slide, I already mentioned it, but I just wanted to say again, the importance of supporting our current workforce in advancing in their careers as clinicians. I actually left out one of the health workers. There should be one additional health worker that was pursuing their MSW, also at San Francisco State, and it was that BEST worker through the Office of Coordinated Care. And then the last bullet point there, you'll see that I said senior clerk at Holy Names MA in Forensic Psychology program. I was going to complete the line and say on their way to becoming ... but I learned that this person actually stepped into a leadership role with DPW. So not within our same department, but still supporting the workforce. Next slide, please. Looking now to the folks that are coming into the door this year, we see a slight dip in the numbers, 18 students compared to last year's 23 at 10 civil service sites compared to last year's 12. But if we look at the degree breakdown, we see that we're actually hosting one more PsyD student than we did last year. And we actually had 2 potential placement sites for PsyDs, 2 more than we did the previous year. And that was because CCDC, Chinatown Child Development Center, and Mission Mental Health both had psychologists that were looking for psychology students. The one at Mission Mental Health did not match with a student, but CCDC did, and so that accounts for the growing number of PsyD, even though we see the slight dip in overall numbers. point I want to make about the change in placement sites has to do with a later point around vacancies, is that as programs struggle with vacancies, it impacts the staff's ability to volunteer, to take on the supervision duties. And so we'll see, if we compared the placement sites of this year to last year, we see a few went offline, such as South Van Ness Adult Behavioral Health, and Chinatown North Beach, they're still having interns, but their numbers went from 5 to 1. And that has everything to do with folks moving, reassigning to other positions, or being sent to Laguna Honda and no longer able to fulfill his supervisory duties. So we see this relationship between current vacancies, ability to offer placement, incoming interns, which then later on down the road feeds into not having the people. So it's all related. You know, if we think about the pipeline as this system made up of interrelated parts, then we start to see, and I think I'm getting ahead of myself with my talk now, but then we see how when we work to reduce hiring times and to really support filling vacancies, we are supporting the pipeline as well, because we're making sure that there are future placements, more interns. So yeah, it's all related. Next slide, please. So here again is that org chart view of this year's placements. A little bit shift in placements. You see that the Office of Coordinated Care one went offline. We have some that are still around. Yeah, not much more to say about this slide. Next slide, please. All right, shifting gears a little bit, I'll talk about the Multicultural Student Stipend Program. This stipend program is a really important way that we support the training and education, not only of our civil service interns, but of those placed at community partner agencies, CBOs, city-funded programs. It's a way that we can support the city's workforce more broadly. You'll see it's been around since the late 80s, stories say. We formalized a new policy around it last year. And as I mentioned, we were able to add additional monies to the budget, which helped us award more students, awards ranging from 1,000 to 500. Last year, we awarded 60 students. Next slide, please. So these next slides kind of give you an idea of who those students were that we awarded. This slide shows, breaks it down in terms of gender identity of the 60 awardees. Next slide, please. Here you see the race and ethnicity breakdown of those 60 awardees. I left Native American as 0 because I think it's important to recognize not only who are we inviting into our system, but to see who is not there and where we need to direct recruitment efforts. And in addition to grouping people together in the groups that we know, I thought it important to also honor how folks are self-identifying. And so in the kind of word blurbs, I don't know what you call those, you'll see the actual phrases, language that people used to self-identify in the application. Next slide, please. This slide shows the school breakdown. So where are those students studying at? And you'll see that the Bay Area schools hosted the most interns that we awarded. If you kind of run through that chart counterclockwise from San Francisco State. And then the schools that we awarded the lesser amount of students, you'll notice in there some of the online programs, Columbia's online MSW program, Arizona State, some of those non-Bay Area schools. Just interesting to think about the folks that are either pursuing their degrees online or who have traveled for their internship placement. Next slide, please. This slide shows language ability of those 60 awardees. And so what languages are folks able to provide services in? And we see that monolingual English speaking is that largest group. And if we were to collapse Mandarin and Cantonese together as one, that would be the next group, followed by Spanish. And you'll see Polish, Arabic, and Tagalog had one speaker each. Next slide, please. Oh, am I there already? Okay, challenges and opportunities. So I already kind of spoke to the impact of vacancies on being able to provide placement sites for future interns. Let me just glance at my notes to make sure I'm not missing something. Yeah, so I guess the question remains to that second bullet point, like how do we incentivize and support our current staff so that they feel able to take on those responsibilities? How do we hold this question of a pipeline in our minds when we're thinking about things like productivity standards or just the rate of vacancies or caseloads? How do we leverage financial incentives to support folks being able to take on interns? San Francisco is part of a Greater Bay Area Regional Partnership, to that last bullet point, of the California Mental Health Services Authority. We sit alongside all of our neighboring counties, even as far as like San Benito County, Napa County. We're all part of this Greater Bay Area Regional Partnership, and through that we receive state MHSA funds to go towards workforce programming. Some counties are thinking about how to leverage those workforce dollars to incentivize supervisors. Are there ways that we can leverage those monies to support them in doing the work so that we have more folks being willing to say, yes, I can take on an intern? And then just briefly about the opportunities to collaborate. Cal Mesa, the partnership, I already spoke to that. This year, I also took part in a bunch of stakeholder interviews for the Mental Health SF Implementation Work Group. And I shared with the analyst who was working on a report for recommendations a lot of what I shared today. And my hope is that in telling the story about the interns, about this need to build out the pipeline and how vacancies is related to all of that, there'll just be more eyes and attention on these important issues. The DHR Workforce Initiatives Coordinator, that is the person, Maribel Mora, who I mentioned before. And I've been working closely with her and the other folks in my roles in their different divisions to see how we can work together in this work. SF Youth Works, that is a newer program out of the mayor's office, and they offered paid internships to high schoolers this summer. And I supported that work by just going and participating in some workshops for the students there. As well as Faces to the Future, that is our high school internship programs. And we have a goal of setting up 2 in-person workplace-based internships for the high schoolers this spring. And so I'm participating in this advisory council just to see how we can do targeted outreach to our programs to see about with that goal of setting up placements for those teens this year. I think that's it. Next slide. Thank you.
Great.
Ask you,
There's no one on the public comment line. I'll just note.
sorry, I keep forgetting.
There's nobody there.
As I mentioned to you before, this is, wonderful. It really warms my heart that this pipeline is operating and moving and going. You've done a great job.
Thank you.
one of my questions, because I know I had asked, I understand about the supervision and the vacancies, and when you're talking about, I don't need to get into the weeds, but just help me understand, because
Yeah.
I run an internship program too, and I understand that. But when you were saying incentivizing and supporting supervisors, they're already within DPH. Does their supervision go towards their productivity of what they need to do? Or how does, I don't know if that is a problem.
I believe so. And actually, Angelica might be able to answer this question better, but I believe so, yes. But what I've heard anecdotally from the supervisors is that it's not enough and that it doesn't account for, like on paper, they have to offer at least 1 hour of individual supervision. But what I'm hearing from folks that have gone offline, like the folks at South Van Ness Adult Behavioral Health, is that the 1 hour isn't enough, and it's not actual the reality of the work when you take into account all of the note reviewing and then just all of the things that come up outside of that 1 hour. So I think there's work to be done, improvements to be made. Yeah,
So it's 1 hour per intern per week.
correct. At least, yeah.
Yeah, I think that that itself is a full-time like
That is,
commitment.
that's
Yeah.
almost a super minimum.
Right.
I mean, for our postdoc fellows, it's 4 hours, or whatever. Have you ever, I mean, the San Francisco Unified School District, their intern program, their behavioral health intern program, has like classes once a week. Have you ever considered partnering with them so that the supervision on your end might be less or whatever? I'm just wondering.
I haven't thought too much about the school district, but that's definitely an avenue I'd love to pursue. I didn't mention in the presentation, but I do host a weekly didactic group for the interns. Not all of them attend the group that I hold, but last year I had about 14 of the interns. Sometimes they have class or other things during the time, but we provide trainings through that group around different system of care things, how to navigate the system, but also various clinical modalities. But yeah, always looking for opportunities to partner and use the resources more efficiently and not create the wheel every time. Absolutely.
That's all I was thinking of. I mean, that counts for another hour of group supervision and just trying to relieve any of the, what your challenges are with the supervision, because I understand it since I do it. So, but that's where you may, within other, city departments, whatever, would be able to consider partnering.
Yeah, definitely.
I have questions like, have you actually also considered, community-based organizations maybe, because a lot of them offer mental health services, but I don't think that they necessarily have the resources to set up an internship program. Like, for instance, San Francisco Community Health Center. And I think that they would welcome something like that as well. So would that be something that we can reach out to, or that's a stretch?
I think it might be a little bit out of my scope, but when we look at the MSSP numbers from last year, you see the majority of them are folks placed at community-based organizations. So I think, there are some like SFHCC or SFCHC, Community Health Center, that have a lot of work to do in terms of growing their programs, though I am in connection with their behavioral health director right now. But then you have organizations like CYC that they have a really robust internship program. So I think with community-based organizations, there's a wide range. yeah, I don't know what support we can offer to help them. Yeah.
Yeah, sadly, it seems like there's never enough who's interested in like mental health and, you know, substance abuse like services. So yeah, behavioral health always seems to be a challenge on top of research. That's the other challenge. Yeah.
Yeah, and the fact that you got 18 for this new cohort is great, since I know just my experience has been so many in their PsyDs and it's MFTs, I want to go into private practice rather than into community work, so.
Yeah. And also, I just want to thank you for being so intentional to include the 0% for Native American, because that really helps us, you know, like not to have to ask like questions. How come there's like a group missing on this chart?
Yeah, definitely. I mean, as a Samoan and as a mixed person, I'm always looking for my numbers. And when it's 0, I want to see that it's 0. So I absolutely make sure to mention those that we need to be doing better work with.
Well, you're a good example for people.
Thank you.
Thank you very much.
Thank you.
Really appreciate it.
Thanks, Ryan. We can move on to item 4, the housing conservative update, and I'm going to make one quick adjustment to the microphone. Even for me.
And I will apologize in advance because I am recovering from a cold from the baby, as is my constant life. So, but very grateful it's just a cold.
Give me 30 seconds to pull up the
No problem.
thing.
Thank
I
you.
apologize. Okay.
All right, thank you so much. Good afternoon, Commissioners. Happy to be here today to provide 2 updates. I know first about housing conservatorship and also about assisted outpatient treatment. Next slide, please. So just to provide some general updates and to reorient us to the conversation around housing conservatorship, this was a pilot that was an update to the Welfare and Institutions Code that is set to sunset in December of this year. From what we know right now, there are no plans to modify the criteria or to extend. There is other work being done around modernizing the LPS Act, including Senator Eggman's Senate Bill 43 that is being looked at. But the current process around housing conservatorship looks like it will sunset as expected, December 2023. So just to, again, reorient us to the conversation to provide some updates, the Housing Conservatorship Program is designed to support individuals who are cycling in and out of crisis, who are deteriorating over time. It has particular focus on ensuring that we're offering individuals voluntary services at every step in the process, and that individuals don't qualify for other services and other court-ordered interventions, including LPS conservatorship and assisted outpatient treatment. Next slide, please. Delving more into some of the specific criteria, and you'll see as we talk about how few individuals have been served by this program, some of the limitations around this, is that individuals have to be diagnosed with both a mental health diagnosis and a substance use disorder. They have to be decompensating, be incapable of providing for their own well-being, have 8 or more 5150s or involuntary psychiatric holds within a 12-month period, and have been offered but declined voluntary services. And just to say around that, not only do they have to have been provided that, and we have to show the court that that's been offered, but there's very specific documentation that's required under the legislation. So, and I know we've discussed this before, but you can imagine as we partner with other hospitals, having that level of specificity in the notes has been complicated. Next slide, please. So I should note this is information from Psychiatric Emergency Services at Zuckerberg San Francisco General Hospital. Of course, we have our most detailed information from that hospital, and I'll be speaking a little bit more around the data limitations that we have from other hospitals in San Francisco. But this is looking at 5150s or involuntary psychiatric holds over time. We, of course, always think it's important to show how this changes over time. So as we're focusing on our most recent fiscal year, it is also important that we look at how the landscape has changed since the program started in fiscal year 18-19. And this data goes through fiscal year 21-22. The reason why we look at 4 or more involuntary psychiatric holds is the legislation requires that starting at a 5th 5150 or involuntary psychiatric hold, we have to start noticing a person that they are on the pathway to housing conservatorship. So for the 5th, 6th, 7th 5150, we have to provide them with a notice saying that this is your 5th 5150 or your 6th 5150, you're on the pathway to housing conservatorship. We'd really like to support you to engage in voluntary services. After we've done that, then on the 8th 5150, we can submit a petition for housing conservatorship. Again, you can imagine as we're partnering with other hospitals, as we know people move in and out of emergency services, sometimes rapidly. Typically, when we've moved forward with cases, what we found is that they have more than 8 5150s in a 12-month period to ensure that we have the necessary documentation for those cases. What we know from the data that we've collected through our housing conservatorship evaluation, which I'll be speaking more to, is, and our best information, again, with limitations, is that there's roughly 13,000 5150s that occurred in San Francisco in fiscal year 21-22. What we know from Zuckerberg San Francisco General Hospital is that the average was 2 visits to psychiatric emergency services. So we're talking about a very small number of individuals who account for many 5150s in our system. And again, you can see over time that number has stayed relatively consistent. Again, I do want to note that we have many limitations when it comes to collecting data from other hospitals, particularly as we look at sensitive private health information and understanding how individuals may be bounced from hospital to hospital. And when we look at the totality and serving a whole person, really having that contextual information. There have been some landscape changes that I think are important to note that we are working to implement, some of which went into effect January of this year. That includes Senate Bill 929, which is really requiring a much larger breadth of information that we report to the state, including demographics to ensure that we have an equity lens when we're looking at who is served on involuntary holds throughout California, how many individuals are seen on 5150s, 5250s, and subsequent holds. And so this has been slowly implemented throughout the year. So we are excited about this. This provides us with additional opportunities to engage with hospitals to receive that information and to look at that totality and to be able to tell that whole story, to have a population focus, which then takes me to AB 2242, which is a much more on an individual level focus. That has not been fully implemented yet at a state level, but that will require that everyone exiting from an involuntary psychiatric hold have a model care coordination plan in place before discharge. And so these two really operating together, again, will provide us with some opportunities to update our LPS delegated agreements with hospitals so that we can gather this information and really partner to ensure that we can be intentional and data-driven from a population level to understand what the landscape is, and also to zoom in on individuals exiting hospitals and how we ensure that they have care plans in place and warm handoffs into services. And of course, that's across our system, but for the Department of Public Health, we are very focused on that and our partnership with the Office of Coordinated Care to make sure that that happens. Next slide, please. So wanted to provide an update of what's been happening with housing conservatorship. So since the start of the program in fiscal year 18-19, there have only been 4 individuals who have been placed on a conservatorship through housing conservatorship. Each one of these cases, though, requires an inordinate amount of time to both outreach, serve, support the individual, ensure that there is documentation, and to move forward with cases. So in the last year, we've only had 1 petition filed for housing conservatorship. 1 case was in process, but then was a better fit and would be better served through an LPS conservatorship. And there were 12 individuals who received notice. They were on the pathway to housing conservatorship. Next slide. When we look at the information, and again, zooming in on the graphic that you previously saw, but for individuals seen at psychiatric emergency services during fiscal year 21-22, looking at individuals who had 4 or more 5150s, and then more narrow, who had 8 or more 5150s, which again is the targeted population for housing conservatorship. What we know for individuals who had 4 or more 5150s is that, of course, they have high rates of being unsheltered, of utilizing urgent and emergent services beyond psychiatric emergency services, unfortunately have high rates of contact with the criminal justice system. Some individuals are connected to conservatorship or LPS conservatorship, and 45% of individuals had an open episode of services within our system, including intensive case management or outpatient services. For individuals who had 8 or more 5150s, we see a slight shift in data. The one thing that I want to highlight for this fiscal year is what we saw is an increase in individuals having coordinated entry assessments, which I think really speaks to the work that Psychiatric Emergency Services has done for individuals who are experiencing housing instability to make sure that they are on the pathway towards permanent supportive housing. Individuals also have a higher rate of being in conservatorship and a higher rate of being connected to services. What this really tells us is we know that acuity has increased over the last couple years in behavioral health services, and we know that individuals, even when they're connected to services, it does not always mean that they are stable or necessarily doing well, and we know that that work can take a lot of time. And so we've really focused on how do we support our providers and our system to reduce any system barriers to support the stabilization of individuals. Next slide, please. So I want to transition a little bit to talk about the requirements in the health code. So there were both state reporting requirements that were focused on individuals who were placed on a conservatorship through housing conservatorship. And then we had health code requirements that really delved into more detail in trying to understand not only who was placed on housing conservatorship, but also the total population and how we support that population. Next slide, please. So this just delves into our first 3 requirements for reporting, and this is a report that was provided to the Board of Supervisors and Mayor's Office. So again, in fiscal year 21-22, there was only 1 petition filed. 2 people were being served on a housing conservatorship at the end of the fiscal year. It's really difficult for us, particularly with the low volume of individuals who have been placed on conservatorship, for us really to evaluate the effectiveness of the program. But what we do know is that we have been able to support individuals accessing services who otherwise were declining those services, and that's been a huge opportunity. And we've been able to support those connections. Again, when we look at the impact of conservatorships established, this is difficult for us to evaluate. What we really have focused on is whether or not somebody was placed on a conservatorship or not, how we've been able to support those connections to voluntary services, which we've been very successful with. Next slide, please. So moving on into requirement 4 and 5, which we have much more information about, wanted to provide some additional information. This looks at the total number of 5150s, or again, our best understanding of the total number of 5150s in San Francisco. There are the limitations that I already spoke to around data collection and receiving that information from hospitals. The information from the Coordinated Care Management System and EPIC, I should say, is from Psychiatric Emergency Services at Zuckerberg San Francisco General Hospital. This is important because not only does it tell us the total number of 5150s, but also unique individuals that account for those 5150s. Unfortunately, we don't have that information from other local hospitals because they aren't able to provide us with that patient level detail. We're hoping that Senate Bill 929 will be able to shift that and we'll be able to tell a better story moving forward. So it's important that we don't add this up and look at 13,000 people as having had involuntary holds, because we don't know unique number of individuals, but we know that there were 13,000 holds placed. And Oregon, what information we have is that roughly 13,000 holds were placed on individuals in fiscal year 21-22. Next slide, please. So moving on into some additional population data, again, it's always been important for us, and certainly for the Housing Conservatorship Working Group, is to really overlay an equity lens. We know that people of color across California and certainly in San Francisco are disproportionately affected by situations that lead to psychiatric instability, but also are disproportionately impacted by court involvement, including conservatorship and court-ordered treatment. And so, again, this gives us an overlay of how this data has looked over years, and also how this compares to the San Francisco U.S. Census to understand individuals who live in San Francisco and how frequently they are held on involuntary psychiatric holds. Again, this data is limited to Zuckerberg San Francisco General Hospital. But what we do see, and we have seen this over time, is that Black and African American individuals account for a disproportionate percentage of cases for both 4 or more 5150s and 8 or more 5150 holds in San Francisco. And for those who are seen at Zuckerberg San Francisco General Hospital. This shows an increase in the most recent fiscal year. This is something that we've monitored very closely. I will say, while we see this in terms of involuntary holds, this is not translated to a disproportionate impact on who has been placed on a conservatorship through the housing conservatorship process. Next slide, please. The last requirement that we have in terms of our report is regarding holds that were placed by law enforcement, and really understanding why law enforcement was involved in a psychiatric crisis versus another entity. So this is data that we have from the San Francisco Police Department. So we have some information from the police department that tells us the reason why they were dispatched to a call, how many cases resulted in a 5150. We do know that the landscape around this has shifted as we've implemented other strategies in San Francisco, including the Street Crisis Response Team as an intervention, and also recently the ability for the community paramedics through the fire department to be able to have authorization to initiate 5150 holds under the auspices of Dr. Cunnins. Next slide, please. So again, this provides data over a period of fiscal years, but just want to note that most individuals who are placed on an involuntary hold by the police department are through a call for a suicide attempt. So these are the CAD codes or the call types of somebody who called 911, how that get coded, why the police department were dispatched to the scene. So most of these situations have been coded as suicide attempts, which of course is not surprising when we transition to the next slide, please. That when we look at this, most 5150 holds have been for danger to self, followed by danger to others, and then grave disability. And of course, this does not totally add up, because as we know, 5150 holds can be for multiple reasons. And then if we can transition to the next slide, I'll just share, we again have a housing conservatorship working group. We have submitted our final report to the Board of Supervisors and to the Mayor's office. The group is continuing to meet through the end of this calendar year until the program sunsets, unless there is any surprising changes at a state level around the program continuing. But we have this information available to the public regarding housing conservatorship. We are continuing to move forward with the program until sunset happens. And of course, I know I just shared a lot of information, so happy to answer any questions that you have.
Any public comment yet?
Let's see. Is there any in the room? Public comment? All right, no one else is on the line.
So it sounds like there might be some confusions too, because the other hospitals are not reporting, like how many unique individuals they served. And there could also be duplicates between hospitals of,
Yeah, absolutely. And I would say less so confusion and just legal, hospitals feeling like they don't have the legal authority to share that level of information with us. And so what we're really working on through Senate Bill 929 is to update the delegated facility agreements so that we are able to receive that client level information, which will provide us with so much information to really understand the population, where they're seen across the city, how we have policy changes at a population level to support individuals on involuntary holds, and also for people that we know are seen across multiple hospitals, how to be much more intentional and recovery-oriented in our interventions.
it reminds me, like, during my days in the substance abuse services, we have all these, like, coordinating meetings at in San Francisco General of all the community-based and hospitals, you know, and we were trying to find clients,
Yeah.
you know, like who might be in one system or the other. So, yeah, so, well, at least this seems like we are moving on toward the right track.
Yeah, that coordination of care is so invaluable.
Couple more questions,
Please.
but you've already answered a couple that we, about, you know, the updated state Senate bills, et cetera, but I was hoping that it was possible to change the number of 5150s being considered, but you said that's not. But my one question is, with the 5150 numbers, what is the age span? Does this include children and adolescents?
I appreciate that question. This is for adults only.
It is, okay. It would be interesting to see, since I know we've had, at least in the CPMC, Van Ness ER, a real uptick in adolescents and kids around age 12, just as there's any way that is possible to be
Yeah, I
put
appreciate
into
that.
the template that somebody fills out.
Yeah, that is certainly reported on in a slightly different way, although it is really important information. Housing conservatorship is limited for adults, but I agree, in terms of our understanding of individuals who are seen on involuntary holds, understanding both 5585 and 5150 holds is very important.
Yeah, it just would be, I think the data would be important for BHS, too.
Absolutely.
In that work, since there is a significant uptick across all. And also, you noted in the 23 individuals that they were currently in the LPS conservatorship.
23%, yes.
Okay, 23%. Do you have, how many individuals are within LPS conservatorship within, let's say, the last year, as you're looking at the housing conservatorship data and the LPS?
Yeah, I don't have, LPS conservatorship is overseen by the Department of, by HSA, the Department of Disability and Aging Services. Unfortunately, I don't have the current information about what their current caseload is, but on average, it's roughly 500 individuals are seen on LPS conservatorship. And I think that there's really a dichotomy in LPS conservatorship. Many conservatorships last for a year or less, and then there are some individuals where it's a lifelong relationship with them where they are chronically meeting grave disability criteria.
Yeah, it's kind of hard sometimes to, understand or have to, differentiate the two, and here we've got 23% who are, cross departments here like that.
Absolutely, yeah.
So,
And like I said, I think there really is an opportunity. We know that the LPS Act, of course, is from 1972, so a little outdated. So there's a lot of opportunity to modernize that. And so as I mentioned, I know that there's a current Senate Bill 43 that Senator Eggman has moved forward that'll really support that. I think what we've really found with housing conservatorship, with it being a goal of having this objective criteria of 8 or more 5150s, really hasn't worked to improve our ability to intervene and support individuals that were the intended population.
I agree. And so I can understand the frustration. And just as I had asked in one of my things, as you said, it's very intensive work. But when the program sunsets in, 5 months or 4 months, then the staff, the DPH staff will move on to other areas. I mean, there's a lot of staff devoted to this.
There, you may be thinking about assisted outpatient treatment, which we'll talk
Okay.
about next.
Yeah.
There are no staff dedicated to this, which has increased our workload, but it will allow us to pivot towards other work, particularly if SB 43 moves forward around our partnership with the Department of Disability and Aging Services.
Okay, yes, you're correct.
So fear not.
That's what I was looking at is AOT, yeah, as well. But it just is of concern and frustration to you. And also, we're hearing it as well. So thank you very much.
Absolutely.
Shall we move on to the next item?
Yeah.
Great. So item 5 is the assisted outpatient treatment update, and I will pull up the same presentation.
Thank you. And I apologize. One, you have me again to speak about this, but also I didn't even introduce myself. I just jumped into the presentation. So Angelica Almeida, I'm with the Department of Public Health, Behavioral Health Services, and I'm the director of the Adult and Older Adult System of Care, which is a different role than I've been in. I previously was the director of the Forensic and Justice Involved System of Care. So my role has slightly shifted, although my work around conservatorship and assisted outpatient treatment has continued. And I think I've shared before, assisted outpatient treatment is a program that is near and dear to me. It's the program that I came to the Department of Public Health to implement, so it was my first role with the department. So it's been a great privilege to both support individuals directly through the program and to see it grow and shift over the years. And I'll say assisted outpatient treatment has been something that's been very successful, which I'll speak more to, and has also provided us with a lot of lessons learned, particularly as we move towards implementing Care Court in October of this year. Next slide, please. So this provides just a little bit of information around where in our system assisted outpatient treatment is. So again, within behavioral health services, our adult and older adult system of care oversees a number of different programs that range from prevention and health promotion to residential services. And of course, we provide this large breadth of services to individuals over the age of 18. We have justice-involved programs through our collaborative courts, including drug court, community justice court, behavioral health court, and how we serve individuals, soon to be care court. Assisted outpatient treatment is, of course, a civil court process for individuals. So similar to conservatorship in that way. However, assisted outpatient treatment is something that sits within the Department of Public Health structure. Next slide, please. So just to speak a little bit more to assisted outpatient treatment and reorient us to the conversation for this update, assisted outpatient treatment is more commonly referred to as Laura's Law in California, and unfortunately is called that based off of the untimely death of Laura Wilcox. But assisted outpatient treatment as an idea is not unique to California. Many states across the nation have AOT programs, although they do vary across different states. In some jurisdictions, it's more akin to conservatorship, where there are opportunities for involuntary medications or opportunities to respond to a crisis. In California, the goal is really intended to get ahead of crises. So for people who have a serious mental illness, who are deteriorating in the community and are not engaged in services, the hope is that we can get ahead of those crises and support stabilization. But important to note that it is not forced treatment, and there is no opportunity for forced medications through this process. Next slide, please. So in San Francisco, we have really focused on a multidisciplinary mental health team that has included both clinicians as well as health workers with the Department of Public Health who've provided both family and peer support services. And also we partner with a CBO through UCSF Department of Psychiatry citywide to provide the intensive case management services for individuals who are court ordered to participate in treatment. Similar to what we spoke to around housing conservatorship, AOT has a lot of opportunities to engage in voluntary services before we get to the court process. In fact, the way our health code is written, it's required that we engage an individual for a minimum of 30 days before we consider filing a court petition. We really talk about this program being a whatever it takes and wherever it takes approach. Our goal is always to develop relationships with individuals. We meet with individuals wherever they feel comfortable. So it could be in a hospital setting, in the jail, in the community, in an alley, at a coffee shop. We really do whatever is necessary and however many outreaches are needed to support that engagement in voluntary services. So this is a small pool of individuals who meet criteria, which I'll speak more to, but again, very intensive work to support this population, which has really led to the success of the program. Next slide, please. So in terms of referrals, the legislation is limited in who's able to make referrals. One thing I will highlight, though, is this is unique in that family members are allowed to make referrals into the program. Most referrals we receive in San Francisco are from family members or treatment providers. There's also a unique focus on supporting family members, providing psychoeducation, regular family support. We know that family members, as I'm sure you all hear, are desperate for opportunities to support their loved ones. I will say what's also unique about this program that we have seen is that we see a relatively high volume of referrals from family members that are out of state, so their loved ones have come to San Francisco, are frequently experiencing homelessness and have serious mental illness, excuse me, and require intervention. Next slide, please. So wanted to provide an opportunity, because it's been a little while since I've been here to present on assisted outpatient treatment, to look at data from fiscal year 21-22, and then for information from fiscal year 22-23, but this is limited that we only have data for the first half of that fiscal year, so through December. When we look at fiscal year 21-22, just to say that over time, our data has been relatively consistent. In that, most individuals we work with identify as male and are between the ages of 26 to 59. I will say similar to what we see with housing conservatorship is that individuals, there's a higher rate of Black and African American individuals who are referred to our program, certainly than we see in the general population, but most individuals who are referred to the program identify as white or Caucasian. In fiscal year 21-22, we served a total of 85 individuals. 9 of those cases we had received repeat referrals for in previous years. Excuse me. And just to say again, recognize that 85 individuals does not seem like a high volume of individuals. The criteria for the program is very narrow in that individuals have to have 2 or more psychiatric hospitalizations, so not including PES contacts, but admissions to inpatient units within a 36-month period, or 1 or more documented threats, attempts, or acts of violence towards themselves or others in the last 48 months. How the court has really looked at that is not only does it have to be a threat, but it had to be a substantial threat. So typically that led to either a hospitalization or incarceration. So we're talking about a relatively narrow pool of individuals that meet the criteria, although individuals that we know are on a pathway and deteriorating, and so really an opportunity for us to engage them and support that stabilization. Also to note that while we served 85 individuals, I know we spoke to this earlier in terms of our pipeline, but we experienced high rates of vacancies across our programs. And so we had 2 clinicians who served this population during fiscal year 21-22. So when we look at it in that scale, like this actually is a huge volume of individuals that have been served, particularly the level of intensity of not only the acuity that we see with the population, but intensity of the outreach and engagement of the individuals. Next slide, please. Again, for fiscal year 22-23, this is really looking at data through December of 2022. And again, very similar information in terms of demographics, primarily male, between the ages of 26 and 59. Also, most individuals referred identify as white or Caucasian. So in just those 6 months, 61 individuals were served during that time period, 7 of which had duplicate referrals to the program. Next slide, please. So again, as I've noticed, as we've talked about, most individuals are referred from treatment providers or family members. So we've had that opportunity to support families throughout our program. This has been a huge opportunity in our system and to support families, again, who have been really desperate for those resources and that connection. Next slide. When we look at outcomes for individuals, again, this has really been consistent across years. So I'll provide a little bit of context, but also want to overlay this. And we had a 3-year evaluation for the program in 2018. And what we saw is that there were statistically significant reductions in negative outcomes. We really have seen that continue, which I think speaks volumes of the commitment of the team and the engagement of individuals in the community. Very few cases result in a court order. In fiscal year 21-22, there was only 4 individuals who had a court order to participate in treatment. The reason for this is because we are very successful in engaging individuals in voluntary care. Over the years, that has ranged from 60 to 70%. But again, these are individuals who have not accepted treatment, are deteriorating in the community. So when we look at, 3/4 of the population accepting services, this is a huge opportunity for us, and again, really speaks to the commitment and ability to engage and meet people where they're at. When we look at longer-term outcomes for individuals, we've had very consistent connections to care. Very few individuals have required a higher level of care, including conservatorship or hospitalization. And overall, we've had reductions in negative outcomes, including reduced psychiatric emergency services contact, reduced psychiatric hospitalizations, reduced incarcerations, and reduced housing instability. So when we look at the impact on these individuals' lives, it's been hugely impactful. And again, not only do we see that immediate impact, but when we've done retrospective analyses, that impact has continued over time and that stability has continued. Next slide, please. So again, just want to share, of course, for the public, we want people to call us to consult about any cases or to see if their loved ones meet criteria. We have a referral line and also an email address where people are able to reach us so that we can support them and identify if they're appropriate for the program. And of course, let me pause again and then see if there's any questions.
Let me check the public comment line real quickly. There's still no one on the line.
I just want to go over, because you're giving more facts and figures so I just want to make sure I totally understand.
Of course.
Okay, if that's okay. So your overall goal is to get ahead of a crisis. And for those that are referred from either a treatment provider or a family member, initially the push is for voluntary care. And in those that you have that are within AOT, 60 to 70% were in voluntary care, and few needed the court-ordered treatment.
Correct.
And the criteria for entry into AOT is 2 or more psychiatric hospitalizations in 36 months. Am I correct?
Yes, it's 2 or more psychiatric hospitalizations or incarcerations where somebody received mental health treatment in the last 36 months.
Okay, or incarcerations. Okay. For mental health? Okay.
Yeah, and this is always a point of clarity. So not incarcerations for mental health, but incarcerations where they received mental health treatment.
Okay. Yeah, receiving, okay. And I think I have this 21, 22, 78% of those in outpatient treatment were male aged 26 to 59 with a higher percentage of Black African Americans. And you served, AOT served 85 clients with 2 clinicians, which is super amazing. That's all I can say, you know.
It's a wonderful team who have been there for a while, and I think, again, really speaks to not just the team cohesion, but their commitment to the work.
But it's still a lot of patients they're seeing.
It's a lot, yeah.
It's very intense work with, 43 people they're each responsible for, or give or take, whatever. Okay. And the outcomes are obviously consistent connection to care. And again, few cases require court order. Do you have any data in the consistent connection to care, how long those referred who are under voluntary care stay in care?
I don't have current data. As I mentioned, we had a 3-year evaluation. And what we found during that 3-year evaluation is that, and I forget the exact percentage, but most individuals remain connected to care, and the impact around reductions in negative outcome had continued over time.
So but they remain in connection to care for how long? 12 months, 24 months? On the caseload, that's what I'm asking.
Yeah, so of course there's variability because
Right.
we were looking at like the last 3 years. So some people hadn't been out of the program for that long, but there were some individuals who had been open in the program in year 1, and when we looked at it 3 years later, were still connected to care, and that was the majority of cases. Unfortunately, I don't have the exact percentage in mind.
That's okay. Are you continuing to collect that data, the consistent connection to care?
We do, yes.
Okay. This would just be something in the future on a DPH media basis or whatever, on those kinds of numbers and the success of AOT should be publicized, or, you know, the folks who are always kind of complaining.
I remember the controversies when we were first implementing it, and, you know, like, yeah, even ACLU was complaining about it. But I think that this is great, and like Commissioner Geraldo said, you know, like having, you know, like the outcomes also being reported would be really helpful for us also, you know, like, so that we know we are investing in the right programs.
Absolutely appreciate that. And we've talked about like relatively a narrow pool of individuals meet this criteria. And there was a ton of controversy early on when I started.
I remember that.
Yes. And just to say, like, and I think that's fair because again, we know that court-ordered interventions disproportionately affect communities of color. And I'm very proud in San Francisco. We know that this can look different across the nation and the state, but in San Francisco that we really have this recovery and wellness approach to the work, which of course doesn't mean that we shouldn't look at our impacts and how we're working with individuals and how court-ordered interventions are used. We absolutely should, but I think we do so much, particularly through the Mental Health Services Act, which I should say funds the assisted outpatient treatment program, to focus on that recovery and wellness and those interventions.
Thank you.
You mentioned just at the beginning the implementation in October of the Care Court.
Mm-hmm.
What do you think the impact will be on AOT, or what do you see your integration into the care court?
I-
You know.
Both will report up to me, so I should say
Okay.
that. And I will say, care court is meant to be upstream from assisted outpatient treatment, from conservatorship, so even a step ahead. The criteria is much broader than assisted outpatient treatment, in that it's focusing on individuals with a schizophrenia spectrum diagnosis who are not engaged in care, so it doesn't have the same criteria around multiple hospitalizations, incarcerations, et cetera, so much broader criteria. I don't think we really will see overlap. And there's opportunity when we are assessing individuals for care court to determine if they would better be served by a different program. Both programs, as I mentioned, will report up to me. And a lot of the language and lessons learned from assisted outpatient treatment were lifted identically from the legislation and put into care court, so that there's some benefit there. We are modeling it in San Francisco in the same way that we have a DPH investigation and engagement team that will determine if somebody qualifies for care court, do that initial engagement and support linkage to voluntary services, and then we'll partner with our system of care to provide the services. So we've really used AOT as a model for how we will be implementing care court in just a couple weeks, which is terrifying to say, so.
Well, but that's, I guess, also, to be honest, my concern with individuals identified then who would benefit or may be, a little more than voluntarily transitioned into AOT, so to speak, initially, with two staff. And whether or not you're able in this, as Ryan mentioned, with the pipeline and with, et cetera, being able to recruit or have new position within
Yeah.
there. I mean,
We'll, of course, need to monitor that very closely. Our numbers have been fairly consistent over the years for AOT, and so I think because of how specific the criteria is, I don't imagine care court will increase that significantly, but I appreciate that, and you're absolutely right. We'll need to monitor that closely.
no, I don't want to burn these people out, put it that way, they're working hard.
Absolutely.
But then the criteria for care court is schizophrenia?
Schizophrenia spectrum.
Okay. So all of the diagnosis on the schizophrenic spectrum then? Okay.
Correct. I should say, like schizophrenia, schizoaffective disorder, it does not include bipolar disorder.
Okay. Interesting. Okay, yes. Okay, thank you. This was very helpful, and I also very much appreciated the kind of extra annotation you did throughout the slides. I think I understood it even better than with the slides, so I appreciated that.
Of course. Well, thank you so much for having me.
Thank you.
Great, so we can move on to item 6, which is emerging issues. There's no one on the public comment line. I'm not hearing any comments from you, commissioners, so we can take item 7, which is general public comment. There's nobody in the room, and there's nobody online. So now we can go to a consideration for adjournment.
Motion to adjourn?
Second?
Oh, and all in favor?
Aye.
Aye.
All right, thank you.
Thank you.
Thank you both.
Thank you.